All right, fun and quick story for you all. So, I came into the team room, and one of my outstanding interns mentioned, "Hey, can you believe Mr. B has a pulmonary embolism?" And the reason that he was surprised was because the patient had absolutely no symptoms. So now I want you to try to back calculate what you can infer from that statement. And in order to do that, I think we first have to revisit what a pulmonary embolism is, and as a result of that, what symptoms are expected. So, Masa, maybe you can kick us off by just anchoring us in the reality of what you view a PE as, and therefore what symptoms you might expect from it.
Okay, so pulmonary embolism is a clot that happens in the pulmonary artery, so it blocks blood flow and causes a VQ mismatch. So we would expect tachypnea and hypoxia sometimes as well, maybe not sometimes, and chest pain later. That's yeah.
Yeah, you laid everything down for us to analyze. Yeah, it's a block in the pulmonary circulation that results in a variety of things related to the lungs, related to perfusion, so on and so forth. Excellent. Um, Nicola, I'd love to ask you. I'm curious how the left-sided equivalent, aortic stenosis, which is a blockage of the outflow of the LV, analogous to the blockage of the outflow of the RV from a pulmonary embolism. How do you imagine aortic stenosis to be different than a pulmonary embolism, since both share blockage from the ventricle as a common feature?
This is a tough one, I think, and
Yeah,
I think I'm gonna go into my philosophical mode
you
again.
said it, not me.
So I think it's there's a big difference between having an impairment to flow from the right ventricle to the periphery as opposed to the left ventricle to the periphery. And I think we kind of sometimes don't really pay much attention to the right ventricle, but the right ventricle is preload dependent, volume dependent, and if you clamp off the vena cava or the preload to the heart stops. While if you clamp off the aorta, the heart is not going to stop, but the cardiac output is going to diminish. The pressure is going to increase a lot in the left ventricle, and this is basically what aortic stenosis is, right? So you're clamping off the aorta, the pressure in the left ventricle is rising. You can get hypertrophic changes to the muscle, but as long as it's not, a severe stenosis, the patient is usually not going to have any symptoms. And then once the stenosis gets severe enough, the patient can get a syncope or a cardiac arrest. But a PE, yeah, it's different. It's more sort of pressure overload of the right ventricle, and if the right ventricle suffers, um, yeah, I think I kind of got lost there. But
Yeah, you said some really powerful things there. You said the location matters, but you also used the word hypertrophy, and I think I think that word really captures a key difference, which we'll revisit. I have to analyze another aspect also. Um, and Anmol, maybe I can ask you. We have to go into a completely different space, and that space is um, a patient's leg, and asking ourselves how a DVT presents compared to an arterial thrombosis. So if you were to see two patients side by side, one of whom had the DVT and the other whom had an arterial thrombosis, both in the same leg, say the right leg, how would the presentations be different?
I think the arterial occlusion will present in a more severe way than a venous occlusion. We will have, I think, pallor, cold leg, and excess pain in arterial occlusion. But in the DVT, we will have, I think, edema and pain as well. And I actually lost you there in the first two questions. In fact, I was thinking about the pulmonary embolism when the patient is asymptomatic. I have seen those cases like that initially they are asymptomatic, but they have impending compromise after that. That means they are going to have dyspnea. I've seen patients like that, but I'm not sure what you were asking.
Yeah, oh, don't worry, we'll get it. We'll get there. Don't worry. We'll put it, well, this is just chapter one. May I ask you now to sort of reframe your answer, which is correct, with a different lens? So if I give you two options, impaired forward flow or impaired return. So if we're defining the idea that symptoms are accumulating because of accumulation of blood or deficiency of blood, which patient would you attribute deficiency of flow and which one would you attribute accumulation of flow?
So impaired forward flow or deficiency of blood will be in the arterial occlusion, and impaired return, venous return to the heart, or excess of the blood will be in the venous occlusion.
Outstanding. Exactly right. Exactly right. So Magnus, if we go back to Nicola's tension, do you what do you categorize aortic stenosis as predominantly? An issue when it becomes symptomatic, an issue with forward flow or an issue with backup, do you think?
I think that would be an issue with forward flow because the heart has to work more to get the blood to the aorta.
Yeah, exactly right. Exactly right. And Valia, what do you categorize the symptoms of a pulmonary embolism as? An issue with backwards or forwards flow? What do you think?
Yeah, I think probably backwards, like I associate it with like congestion.
Yeah. Yeah, exactly right. Exactly right. This is a little bit of a philosophical question that I'll ask Kirtan. Kirtan, what is an artery and what is a vein? We haven't defined those. We defined everything else, including what a PE is, but what is an artery and what is a vein?
Right. So there are two different ways, right? What function it serves for particular organ and what do you see histologically? Like histologically speaking, if you are on planet Mars and I just give you a sample of like a vein or artery, then you won't be able to tell apart, right? Which artery is this, vein is this. But then if you take the human body in context, so the artery and vein doesn't make sense. Only thing we care about is that you are giving the blood through the pulmonary arteries to the lungs, right? And then pulmonary veins are draining it back to the heart. So I guess whether the congestion happens or whether the forward flow is interrupted depends on the severity of it. Like if it's a saddle pulmonary embolism, then you are choking off the blood supply to lungs, right? And if it's a subsegmental PE, doesn't matter. Right?
Yeah, you're absolutely right. I think that, well, you're right that the definition really is a histological one, but if you ask yourself an interesting question, which is why does a DVT not result in proximal ischemic symptoms? So there's a blockage of the vein, say in the knee. Why does the thigh not get ischemic? And the answer is because the perfusion of the thigh is still intact as the arterial circulation drains into the capillaries and is resorbed into the vein. So fundamentally, there is no problem in the thigh whatsoever. Fair? And if you ask then the corollary of why in a patient with an arterial thrombosis, say at the knee, why does the thigh not get swollen as a result of the accumulation of arterial blood that's not making it further down into the knee? And the answer is quite simple. It's because the venous capacity of the thigh far exceeds any accumulation of arterial blood, and it returns all of it to the heart. So now, even though the world has been telling us to call this thing the pulmonary artery, the question is, which I'll ask Lyra to reflect on, from a perspective of returning blood or giving blood, what do you view the pulmonary artery as? More a return vessel or a delivery vessel?
Yeah, that's interesting because it's basically an artery, so I guess it's structured as an artery, but it contains venous blood, so it's technically hybrid or something like this.
Yeah, it really fundamentally is a vein. And let me propose why, from a flow perspective, it's a vein. It is no different than the popliteal vein. It is returning blood away to the ultimate central source, the left side of the heart. A very, very high pressure system that is designed to permeate blood and oxygenate the blood throughout the rest of the body. And the key characteristic that allows it to function as a relatively low pressure system, returning blood to the left side of the heart, is the fact that the organ it is returning blood to, the lungs, is perfused by an entirely independent system called the bronchial circulation. And the symptoms of a blockage in the pulmonary artery would be very, very different if there was no collateral blood supply. Very, very different. And let me try to illustrate that point to you all by going into a completely different space. So David, if you were trying to share with your junior resident on your shift a quick illness script for acute portal vein thrombosis, or even subacute portal vein thrombosis, how would that show up?
Yeah, I think it happens mostly in cirrhotic patients, and is one of the main causes of, well, one of the causes of the compensation of cirrhotic, and could present with other other features of the compensated cirrhosis. If not, yeah, shouldn't cause like clearly right upper quadrant pain or liver dysfunction or anything like that, but more retrograde problems.
Right.
Just maybe even mesenteric ischemia could be one of the features and all of that. Yeah.
Excellent. Yeah, you said it. You said the details and you said the key principle. A portal vein thrombosis in the vast majority of instances causes retrograde problems, in large part because the liver is spared by collateral circulation from not the bronchial circulation, but the mesenteric circulation and the hepatic artery. So if you do a thought experiment and say that somebody has no hepatic circulation, what's hepatic arterial circulation, how would a portal vein thrombosis present? It would choke off the liver. There's no other source of blood supply. So why do the lungs care at all about what's happening in the pulmonary circulation when there's collateral flow from the bronchial tree? So Anmol, let's go back to the DVT, okay? So you're there, you're taking care of that patient with DVT, right? And all of a sudden, while you're in the other room taking care of the patient with arterial insufficiency, suddenly that patient with DVT says, "Oh my gosh, doc, I have chest pain. It's really pleuritic." What just happened?
The clot returned back to the heart, the right
Yeah,
side of the heart.
exactly. How do venous issues present with forward disease? Thromboembolism. And the term is venous thromboembolism. So Alex, I'm curious, in your experience now, a whole year of taking care of those beautiful, very thin-walled alveoli, how often have you seen pleuritic chest pain in a patient with PE? Would you say it's sort of mild, moderate, or universal, you think?
I wouldn't say universal. I would say I think when a patient, if I'm recalling correctly, I think instances when I've seen it are when patients have relatively mild symptoms. So like when they have maybe like a segmental or like a subsegmental PE and they're not so short of breath, then maybe they have pleuritic pain. Or like a patient I had yesterday who came to the ICU for a high risk PE getting TPA. Like that patient was dramatically short of breath and dizzy, and I wonder if he might develop pleuritic pain as his clot burden decreases, and really he might be focusing more on his pain and less on his more detrimental symptoms.
What a powerful illustration of the pathophysiology, Alex. That's so cool. Yeah, if you ask yourself what happens, why do patients get pleuritic chest pain? And the reason patients get pleuritic chest pain is they infarct their pleura. And that pleural infarction can be just a pain predominant syndrome, but sometimes it can actually infarct the pleura to the point where you get a pleural effusion, and the pleural effusion can be exudative, can even hemorrhage. And the pleura is much more the source of ischemia, being a distant organ, than the lungs themselves. But the lungs themselves can get infarcted and cause a wedge-shaped infarction and ultimately form a cavity, and the patient can bleed. In a patient who has a venous thrombosis, the universal feature will be backup. Universal. And occasionally, thromboembolism flicks off and blocks further downstream. And the further downstream you're blocked, the less collateral circulation you have. Why does a wedge-shaped infarct from a pulmonary embolism occur, called Hampton's hump? Why have we never seen it in the middle of the right middle lobe? Why is it always pleural based? And that fact helps you understand what's happening. There are two fundamental features happening in a patient who is developing symptoms of pulmonary embolism. The first is that they have a DVT with backup affecting their right ventricle. And a fraction of those patients will go pew. All of a sudden, pleuritic chest pain, maybe an effusion in the pleura, maybe a lung infarction. And so what you will always see is puffiness and swelling. And what you will occasionally see is the consequences of thromboembolism, which it may hurt, it may hemoptysize, and it may result in hypoxemia. Those three H's are an unpredictable feature of a pulmonary embolism, but the other H, hemodynamic consequences, is universal. So, how can that be true at the same time that I've just told you this patient has no symptoms? What do you think, Valio? How can this patient have no symptoms? How is that possible?
I'm not really sure. I don't think I've ever seen a PE without even like tachycardia, which I think is like the minimum on my illness script. But maybe if it's a really, really tiny one, but I'm really not sure.
So Vali, I know you run a lot, and so your exertional capacity is extremely high. And so the reserves that you have, I can't imagine how horrific a disease would have to be to take somebody like you who has so much reserve to feel short of breath at rest. I just saw your comment in the chat. Like, can you imagine how devastating a disease would be to say that your exertional capacity is all the way here and say this is all the way down here is when you would start to feel short of breath at rest? It would have to be a disease this severe. But you're lucky, because people who are similarly fit as you are very likely to detect very subtle drops in your exertional capacity. So even if your exertional capacity went from excellent to 85%, you would notice. So what can you infer about a patient who doesn't notice that his exertional capacity went from blank to blank?
Yeah, I'd heard that their baseline is maybe a little poor, that they're used to some dyspnea.
Exactly right. Exactly right. So I will tell you that this person exists in a motorized wheelchair as a result of paraplegia. And the only reason he's symptomatic is because, unlike Vali, he does not run marathons, and if he did, he would definitely feel it. A fraction of his pulmonary circulation has been compromised. And the question is, does he exert himself beyond that fraction? And ultimately, the range of hemodynamic symptoms of a pulmonary embolism depends on the degree of compromise of the pulmonary circulation, right? I'm going to show you a visual to help at home. To first sort of reestablish that you're always going to get backwards and rarely forwards. Forwards is thromboembolism, backwards is congestion. The pleura, being a more distant organ, is much more likely to be infarcted than the parenchyma. This is what you're going to rely on. And the range of hemodynamic symptoms, maybe I haven't noticed, I only notice when I exert myself, or I'm only short of breath at rest, but my hemodynamics are okay, to hemodynamic collapse in the stereotypical order we know it to collapse. First with tachycardia, then with narrow pulse pressure and orthostasis, and then overt shock. What influences how far along the spectrum you are? Well, of course, naturally, the severity of the degree of the pulmonary circulation. If somebody just removes somebody's pulmonary circulation out of the way, then that is extremely severe. But there are two other variables that are often unknown at that time, which is, what is the patient's exertional capacity? The more they exert themselves, the more and more likely they are to notice, because it depends on here. If you have a PE that is not severe enough to result in this, based on its severity alone, then the distance between this and this is an interpatient variable. If a patient never exerts themselves on exertion, then you see that you can essentially cover this area, and you'll see that so many PEs can fall into the crack that now exists between no symptoms and shortness of breath at rest. And the more and more a patient exerts themselves, the more and more this line moves here. Which is why, if, hopefully it never happens, one of you gets a pulmonary embolism and you have a good exercise capacity, you'll know it instantly. All right, let me stop there and see what questions y'all have.
Rabih, so what prompted the patient to be worked up for PE?
Yeah, so he actually was there for vascular issues, and he was getting a CT angiography of his abdominal aorta, which caught a pulmonary embolism incidentally. I should just share that the rate of errors in seeing a contrast defect is high. So one of the first things we did was, is it actually a real PE or is it just a contrast artifact? So we rescanned him, and in fact, it was a PE on the CT-PE protocol, but completely incidentally discovered, as is an increasing number of PEs, and I'm sure Alex can share many stories on that. Maybe I can actually hand the mic to you, Alex, to see if any other, from your experience and wisdom in the space, any other another perspective that you have, or things that you want to add in or adjust.
Not at all. I learned a ton from the conversation. Thank you so much. I'm reflecting a lot on a patient that I had yesterday who he's 90 and he's in one of our ICUs because he now has a high risk PE, and basically he presented with his baseline functional status. What I learned from him and his wife yesterday is that he can walk without a walker, without a cane, believe it or not, at 90 years old, very slowly, like a block or so.
Mm-hmm.
But for whatever reason, he had been more tired and more bound to his chair or his couch for the past week or so, and developing the progressive shortness of breath. And so I'm wondering if maybe the fact that his exercise capacity was relatively limited based upon his age and frailty is why it had taken some more time to come to clinical light that he had the shortness of breath, and then he really came in with effectively hemodynamic compromise. He wasn't hypotensive, but he did have tachycardia. He had elevated he had a decreased kidney function, increased liver enzymes, and a very central and large pulmonary embolus and a clot all the way down his leg.
Yeah, that's really sad. I think you're spot on as to the reason why it took a while. I think so. And the analogy is true for aortic stenosis too. So if you have mild aortic stenosis, who's most likely to feel it? Elite athlete. Way more likely. A mild stenosis for an elite athlete is a severe issue. And so that's why you really, really have to ask yourself when we say symptomatic, especially for hemodynamic issues, it really depends on the exertional capacity of the person. So if you're an elite athlete, you're in really, really good shape in general, and you're at a big advantage at detecting sinister diseases creeping up on you way, way, way earlier. And the inverse is true. We see so many patients who abruptly, out of the blue, have severe aortic stenosis without any warning whatsoever. Why? Their exertional capacity is so low that the line between no symptoms and symptoms of exertion is so wide that it can hold decades of disease in it without the patient detecting it. So in your mind's eye, I'd love for you to take away one simple message from this session. No symptoms to dyspnea on exertion is a line defined by the patient's exertional capacity. The more they exert themselves, that more line goes to zero. The less and less they exert themselves, the more infinite that line goes. Cool? All right, y'all. Go forth and nerd. And if anyone makes it to all 700 sessions today, please schedule a meeting with me. We should talk about what else we need to do to make your life more full and joyous. And I'll be the first to admit that I'm at risk of doing that. So I have to talk to myself and a little bit of self-reflection. But have a great day, and I'll see you all later. Bye.